Structure of the anterior abdominal wall. It provides a durable and flexible covering protecting the internal abdominal organs. It consists of skin, superficial fascia, deep fascia, muscles, extraperitoneal fascia, and parietal peritoneum. Skin. It is loosely attached to the underlying structures except at the umbilicus, where it is tethered to the scar tissue. The natural lines of cleavage in the skin are constant and run downward and forward, almost horizontally around the trunk. The umbilicus is a scar representing the site of attachment of the umbilical cord in the fetus. It is situated in the linea alba. Skin consists of two supplies, and these are the nerve supply and the blood supply. Nerve supply. It is derived from the anterior rami of the lower 6 thoracic and the first lumbar nerves. The thoracic nerves are the lower 5 intercostal and the subcostal nerves. The first lumbar nerve is represented by the iliohypogastric and the ilioinguinal nerves. There are two dermatome under the nerve supply, and these are the dermatome of T7, which is located in the epigastrium over the xiphoid process, and the dermatome of T12 that includes the umbilicus, and that of L1 lies just above the inguinal ligament and the symphysis pubis. The second supply under the skin is the blood supply. It is a flow of blood throughout the body, and it consists of arteries and veins. Arteries are well known in red, and they are the blood vessels that delivers blood to the body, and the veins, in blue, are the blood vessels that returns blood to the heart. Superficial fascia is a loose connective tissue layer immediately deep to the skin. It is divided into two, and these are the fatty layer or the fascia of Camper and the deep membranous layer or the scarpus fascia. Fatty layer or the Camper's fascia is a continuous with the superficial fat over the rest of the body and may be extremely thick. It is around 3 inches or more in obese cases or obese patients. Scarpus fascia or the deep membranous layer is a thin layer that fades out laterally, and it becomes continuous with the superficial fascia of the back and the thorax. Inferiorly, the membranous layer passes into the front of the thigh, where it fuses with the deep fascia 1 finger breadth below the inguinal ligament. In the midline inferiorly, the membranous layer of the fascia is not attached to the pubis but forms a tubular sheath for the penis for men and or clitoris for women. Under the perineum, it then enters to the wall of the scrotum or the labia majora. From there, it passes to be attached on each side of the margin of the pubic arch, and it is called or referred to as the Cole's fascia. Posteriorly, after that, it fuses with the perineal body and the posterior margin of the perineal membrane. In addition, in the part of the scrotum, the fatty layer of the superficial fascia is then represented as a thin layer of smooth muscle, and this smooth muscle is called the dartus muscle. And lastly, the membranous layer of the superficial fascia persists as a separate layer. Muscles of the anterior abdominal wall. It consists of 3 broad thin sheaths that are aponeurotic in front. From exterior to interior, they are known as the external oblique, internal oblique, and the transversus. Rectus abdominis is a long strap muscle or a wide vertical muscle that extends along the whole length of the anterior abdominal wall, while rectus sheath is a long fiber sheath that encloses the rectus abdominis muscle and the pyramidalis muscle. To add, pyramidalis muscle is a small muscle in the lower part of the rectus sheath, and it is mostly absent. External oblique muscle is a thin, broad muscular sheath that arises from the outer surfaces of the lower 8 ribs and to be inserted into the xiphoid process, the linea alba, the pubic crest, the pubic tubercle, and the anterior half of the iliac crest. Most fibers are inserted by the means of broad aponeurosis, and most posterior fibers passing down to iliac crest form the posterior free border. There is a triangular shaped defect in the external oblique aponeurosis that lies immediately above and the medial to the pubic tubercle, and it is called the superficial inguinal ring. To add, it is the spermatic cord that passes through this opening that carries the external spermatic fascia from the margins of the ring. The process between the anterior and superior iliac spine and the pubic tubercle, the lower border of the aponeurosis is folded backward on itself, forming the inguinal ligament. From that, the medial end of the ligament, called the lacunar ligament, extends backward and upward to the pectineal line on the superior ramus of the pubis. Its sharp, free crescentic edges forms the medial margin of the femoral ring. And because of that process, in reaching the pectineal line, we have the pectineal ligament, which means the lacunar ligament becomes continuous with the thickening of the periosteum. The internal oblique muscle is a thin, broad muscular sheath that lies deep to the external oblique, with most of its fibers run at the right angles to those of the external oblique. The muscle fibers of the internal oblique radiates as they pass upward and forward. The muscle is inserted into the lower borders of the lower three ribs and their costal cartilages, the cyphoid process, the linea alba, and the symphysis pubis. The internal oblique has a lower free border that arches over the spermatic cord or the round ligament of the uterus. To add, in the internal oblique, we have the conjoint tendon, which is attached medially to the linea alba, but it has a lateral free border, as well as the cremasteric fascia, which is a term used to describe the cremaster muscle and its fascia. Transversus muscle is a thin sheet of muscle that lies deep to the internal oblique, and its fibers run horizontally forward. It is inserted into the cyphoid process, the linea alba, and the symphysis pubis. The posterior border of the external oblique muscle is free, while the posterior borders of the internal oblique and the transversus muscles are attached to the lumbar vertebrae by the lumbar fascia. Function of the anterior abdominal wall muscles. It assists the diaphragm during inspiration by relaxing as the diaphragm descends so that the abdominal viscera can be accommodated. The muscles assist in the act of forced expiration that occurs during coughing and sneezing by pulling down the ribs and the sternum. Their tone plays as an important part in the supporting and protecting the abdominal viscera, and by contracting simultaneously with the diaphragm, with the gluteus of the larynx closed, they increase the intra-abdominal pressure and help in the micturition, defecation, vomiting, as well as the parturition. Nerve supply of the anterior abdominal wall muscles, on the other hand, are supplied by the lower 6 thoracic nerves and the iliohypogastric and ilioinguinal nerves, or well-known or most known as the L1. The rectus muscle is supplied by the lower 6 thoracic nerves, and the pyramidalis is supplied by the 12th thoracic nerve. Fascia transversalis is a thin layer of fascia that lines the transversus abdominis muscle and is continuous with a similar layer lining the diaphragm and the iliacus muscle. The femoral sheath for the femoral vessels in the lower limbs is formed from the fascia transversalis and the fascia iliaca that covers the iliacus muscle. Under the fascia transversalis, we have the extraperitoneal fat and the parietal peritoneum. Extraperitoneal fat is a thin layer of connective tissue that contains a variable amount of fat and lies between the fascia transversalis and the parietal peritoneum, which is a thin serous membrane and is continuous below with the parietal peritoneum lining the pelvis. Nerves of the anterior abdominal wall are the anterior rami of the lower 6 thoracic and the first lumbar nerves. They pass forward in the interval between the internal oblique and the transversus muscle. The thoracic nerves are the lower 5 intercostal nerves and the subcostal nerves, with first lumbar nerve is represented by the iliohypogastric and ilioinguinal nerves, branches of the lumbar plexus. They supply the skin of the anterior abdominal wall, the muscles, and the parietal peritoneum. They terminate by piercing the anterior wall of the sheath and supplying the skin. Arteries of the anterior abdominal wall. We have three arteries under this category, and these are the superior epigastric artery, inferior epigastric artery, and the deep circumflex iliac artery. Superior epigastric artery is one of the terminal branches of the internal thoracic artery that enters the upper part of the rectus sheath between the sternal and costal regions of the diaphragm. It descends behind the rectus muscle, supplying the upper central part of the anterior abdominal wall and anastomosis with the inferior epigastric artery. Inferior epigastric artery is a branch of external iliac artery just above the inguinal ligament. It runs upward and medially along the medial side of the deep inguinal ring, as well as it ascends behind the rectus muscle, supplying the lower central part of the anterior abdominal wall and the anastomosis with the superior epigastric artery. The deep circumflex iliac artery is the last artery in the arteries of the anterior abdominal wall. This artery is a branch of external iliac artery just above the inguinal ligament. It runs upward and laterally towards the anterosuperior iliac spine and then continues along the iliac crest. It supplies the lower lateral part of the abdominal wall. In addition, the lower two posterior intercostal arteries, branches of the descending thoracic aorta, four lumbar arteries, branches of the abdominal aorta, passes forward between the muscle layers and supply the lateral part of the abdominal wall.
As superficial veins form a network that radiates out from the umbilicus, while the paraumbilical veins forms an important portal systematic venous anastomosis. Superficial lymph vessels. Lymph drainage of the skin of the anterior abdominal wall above the level of the umbilicus is upward to the anterior axillary group of nodes, which can be palpate just beneath the lower border of the pectoralis major muscle. Deep lymph vessels follow the arteries and drain into the internal thoracic, external iliac, posterior mediastinal, and para-aortic lumbar nodes.
The canal is about 1.5 inches 4 cm long in the adult and extends from the deep inguinal ring, a hole in the fascia transversalis, downward and medially to the superficial inguinal ring, a hole in the aponeurosis of the external oblique muscle. It lies parallel to and immediately above the inguinal ligament. Related to it, medially are the inferior epigastric vessels, which pass upward from the external iliac vessels. The margins of the ring give attachment to the internal spermatic fascia, or the internal covering of the round ligament of the uterus. The margins of the ring, sometimes called the crura, give attachment to the external spermatic fascia. It is a thick-walled muscular duct that transports spermatozoa from the epididymis to the urethra. It traverses the inguinal canal and supplies the testis and the epididymis. A slightly raised ridge in the midline indicates the line of fusion of two lateral labiocrostal swellings. In the female, the swellings remain separate and form the labia majora. This is innervated by the sympathetic nerve fibers and is responsible for the wrinkling of the overlying skin. The membranous layer of the superficial fascia, often referred to as the cos fascia, is continuous in front with the membranous layer of the anterior abdominal wall, sometimes called the scarpus fascia, and behind it is attached to the perineal body and the posterior edge of the perineal membrane. At the sides, it is attached to the ischiopubic rami. Both layers of superficial fascia contribute to a median partition that crosses the scrotum and separates the testes from each other. The external spermatic fascia is derived from the aponeurosis of the external oblique muscle. The charismatic fascia is derived from the internal oblique muscle. And finally, the internal spermatic fascia is derived from the fascia transversalis. The cremaster muscle is supplied by the genital branch of the genitofemoral nerve. The cremaster muscle can be made to contract by stroking the skin on the medial aspect of the thigh. This is called the charismateric reflex. The afferent fibers of this reflex arc travel in the femoral branch of the genitofemoral nerve, the L1 and L2, and the efferent motor nerve fibers travel in the genital branch of the genitofemoral nerve. The function of the cremaster is to raise the testis and the scrotum upward for warmth and for protection against injury. It is the lower expanded part of the processus vaginalis, normally just before birth. It becomes shut off from the upper part of the processus and the peritoneal cavity. The tunica vaginalis is thus a closed sac, evaginated from behind the testis. The left testis usually lies at a lower level than the right. Each testis is surrounded by a tough fibrous capsule, the tunica albuginea. This becomes reduced to a single vein as it ascends through the inguinal canal. The right testicular vein drains into the inferior vena cava and the left vein joins the left renal vein. This is to be expected because during development, the testis has migrated from high up on the posterior abdominal wall, down through the inguinal canal, and into the scrotum, dragging its blood supply and lymph vessels after it. In the male, the genital swellings fuse in the midline to form the scrotum. Within the labia are a large amount of adipose tissue and the terminal strands of the round ligaments of the uterus.
Structure of the posterior abdominal wall.
The posterior abdominal wall is formed in the midline by the 5 lumbar vertebrae and their intervertebral discs, and laterally by the 12 ribs, the upper part of the bony pelvis, the psoas muscles, the quadratus lumborum muscles, and the aponeurosis of origin of the transversus abdominis muscles.
Lumbar vertebrae.
The body of each vertebra is massive and kidney-shaped, and it has to bear the greater part of the body weight. The 5th lumbar vertebra articulates with the base of the sacrum at the lumbosacral joint. The intervertebral discs in the lumbar region are thicker than in other regions of the vertebral column. They are wedge-shaped and are responsible for the normal posterior concavity in the curvature of the vertebral column in the lumbar region.
Twelfth rib.
It should be noted that the head of the 12th rib has a single facet for articulation with the body of the 12th thoracic vertebra. The anterior end is pointed and has a small costal cartilage, which is embedded in the musculature of the anterior abdominal wall. In many people, it is so short that it fails to protrude beyond the lateral border of the erector spinae muscle on the back.
Ilium.
The ilium, together with the ischium and pubis, forms the hip bone. They meet one another at the acetabulum. The medial surface of the ilium is divided into 2 parts by the arcuate line. Above this line is a concave surface called the iliac fossa. Below this line is a flattened surface that is continuous with the medial surface of the pubis and ischium. It should be noted that the arcuate line of the ilium forms the posterior part of the iliopectineal line, and the pectineal line forms the interior part of the iliopectineal line. The iliopectineal line runs forward and demarcates the folds from the true pelvis.
Muscles of the posterior abdominal wall. Psoas major.
Psoas muscle arises from the roots of the transverse processes, the sides of the vertebral bodies, and the intervertebral discs from the 12th thoracic to 5th lumbar vertebrae. The fibers run downward and laterally and leave the abdomen to enter the thigh by passing behind the inguinal ligament. The muscle is inserted into the less trochanter of the femur. The psoas is enclosed in a fibrous sheath that is derived from the lumbar fascia. The sheath is thickened above to form the medial arcuate ligament.
Quadratus lumborum.
The quadratus lumborum is a flat, quadrilateral shaped muscle that lies alongside the vertebral column. It arises below from the iliolumbar ligament, the adjoining part of the iliac crest, and the tips of the transverse processes of the lower lumbar vertebrae. The fibers run upward and medially and are inserted into the lower border of the 12th rib and the transverse processes of the upper four lumbar vertebrae. The anterior surface of the muscle is covered by lumbar fascia, which is thickened above to form the lateral arcuate ligament and below to form the iliolumbar ligament.
Transverse abdominis.
The transversus muscle is a thin sheet of muscle that lies deep to the internal oblique, and its fibers run horizontally forward. It arises from the deep surface of the lower six costal cartilages, interdigitating with the diaphragm, the lumbar fascia, the anterior two-thirds of the iliac crest, and the lateral third of the inguinal ligament.
Iliacus.
The iliacus muscle is fan-shaped and arises from the upper part of the iliac fossa. Its fibers join the lateral side of the psoas tendon to be inserted into the lesser trochanter of the femur. The combined muscles are often referred to as the iliopsoas.
Fascial lining of the abdominal wall.
As mentioned previously, the abdominal walls are lined by one continuous layer of connective tissues that line between the parietal peritoneum and the muscles. It is continuous below with a similar fascial layer lining the pelvic walls. It is customary to name the fascia according to the structure it overlies. For example, the diaphragmatic fascia covers the undersurface of the diaphragm. The transversalis fascia lines the transversus abdominis. The psoas fascia covers the psoas muscle. The quadratus lumborum fascia covers the quadratus lumborum, and the iliaca fascia covers the iliacus muscle.
Peritoneal lining of the abdominal wall.
The walls of the abdomen are lined with parietal peritoneum. This is a thin serous membrane consisting of a layer of mesothelium resting on connective tissue. It is continuous below with the parietal peritoneum lining the pelvis.
Nerve supply.
The central part of the diaphragmatic peritoneum is supplied by the phrenic nerves, and the peripheral part is supplied by the lower intercostal nerves. The peritoneum lining the anterior and posterior abdominal walls is supplied segmentally by the intercostal and lumbar nerves, which also supply the overlying muscles and skin.
Surface landmarks of the abdominal wall. Xiphoid process.
The xiphoid process is the thin cartilaginous lower part of the sternum. It is easily palpated in the depression where the costal margins meet in the upper part of the anterior abdominal wall. The xiphisternal junction is identified by feeling the lower edge of the body of the sternum, and it lies opposite the body of the ninth thoracic vertebra.
Costal margin.
Costal margin is the curved lower margin of the thoracic wall and is formed in front by the cartilages of the 7th, 8th, 9th, and 10th ribs, and behind by the cartilages of the 11th and 12th ribs. The costal margin reaches its lowest level at the 10th costal cartilage, which lies opposite the body of the third lumbar vertebra. The 12th rib may be short and difficult to palpate. The iliac crest can be felt along its entire length and ends in front at the anterior superior iliac spine and behind at the posterior superior iliac spine. Its highest point lies opposite the body of the fourth lumbar vertebra. Pubic tubercle. About 2 inches posterior to the anterior superior iliac spine, the outer margin projects to form the tubercle of the crest. The tubercle lies at the level of the body of the fifth lumbar vertebra. Symphysis pubis. It is felt as a solid structure beneath the skin in the midline, at the lower extremity of the anterior abdominal wall. The pubic crest is the name given to the ridge on the superior surface of the pubic bones medial to the pubic tubercle. Inguinal ligament. The inguinal ligament lies beneath the skin crest in the groin. It is the rolled under inferior margin of the aponeurosis of the external oblique muscle. It is attached laterally to the anterior superior iliac spine and curves downward and medially to be attached to the pubic tubercle. Superficial inguinal ring. The superficial inguinal ring is a triangular aperture in the aponeurosis of the external oblique muscle and is situated above and medial to the pubic tubercle. In the adult male, the margins of the ring can be felt by invaginating the skin of the upper part of the scrotum with the tip of the little finger. In the female, the superficial inguinal ring is smaller and difficult to palpate. It transmits the round ligament of the uterus. Scrotum. The scrotum is a pouch of skin and fascia containing the testis, the epididymis, and the lower ends of the spermatic cords. The skin of the scrotum is wrinkled and is covered with sparse hairs. The bilateral origin of the scrotum is indicated by the presence of a dark line in the midline, called the scrotal raphe, along the line of fusion. Linea alba. The linea alba is a vertically running fibrous band that extends from the symphysis pubis to the xiphoid process and lies in the midline. It is formed by the fusion of the aponeurosis of the muscles of the anterior abdominal wall and is represented on the surface by a slight median groove. Umbilicus. The umbilicus lies in the linea alba and is inconstant in position. It is a puckered scar and is the site of attachment of the umbilical cord in the fetus. Rectus abdominis. The rectus abdominis muscles lie on either side of the linea alba and run vertically in the abdominal wall. They can be made prominent by asking the patient to raise the shoulders while in the supine position without using the arms.
Tendinous intersections of the rectus abdominis. The tendinous intersections are 3 in number and run across the rectus abdominis muscle. In muscular individuals, they can be palpated as transverse depressions at the level of the tip of the xiphoid process, at the umbilicus, and halfway between the two.
Linea semilunaris. The linea semilunaris is the lateral edge of the rectus abdominis muscle and crosses the costal margin at the tip of the ninth costal cartilage. To accentuate the semilunar lines, the patient is asked to lie on the back and raise the shoulders off the couch without using the arms. To accomplish this, the patient contracts the rectus abdominis muscles so that their lateral edges stand out. Abdominal lines and planes. Vertical lines and horizontal planes are commonly used to facilitate the description of the location of diseased structures or the performing of abdominal procedures. Vertical lines. Each vertical line, right and left, passes through the midpoint between the anterior superior iliac spine and the symphysis pubis. Transpyloric plane. The horizontal transpyloric plane passes through the tips of the ninth costal cartilages on the two sides. That is, the point where the lateral margin of the rectus abdominis or the linea semilunaris crosses the costal margin. It lies at the level of the body of the first lumbar vertebra. This plane passes through the pylorus of the stomach, the duodenojejunal junction, the neck of the pancreas, and the hyla of the kidneys. Subcostal plane. The horizontal subcostal plane joins the lowest point of the costal margin on each side, that is, the 10th costal cartilage. This plane lies at the level of the third lumbar vertebra. Intercrestal plane. The intercrestal plane passes across the highest points on the iliac crests and lies on the level of the body of the fourth lumbar vertebra. This is commonly used as a surface landmark when performing a lumbar spinal tap. Intertubercular plane. The horizontal intertubercular plane joins the tubercles on the iliac crests and lies at the level of the fifth lumbar vertebrae. Abdominal quadrants. It is common practice to divide the abdomen into quadrants by using a vertical and a horizontal line that intersect at the umbilicus. The quadrants are the upper right, upper left, lower right, and lower left. The term epigastrium and perioumbilical are loosely used to indicate the area below the xiphoid process, above the umbilicus, and the area around the umbilicus respectively. Surface landmarks of the abdominal viscera. It must be emphasized that the positions of most of the abdominal viscera show individual variations as well as variations in the same person at different times. Posture and respiration have a profound influence on the position of viscera. The following organs are more or less fixed and their surface markings are of clinical value. Liver. The liver lies under cover of the lower ribs, and most of its bulk lies on the right side. In infants, until about the end of the third year, the lower margin of the liver extends 1 or 2 finger breadths below the costal margin. In the adult who is obese or has a well-developed right rectus abdominis muscle, the liver is not palpable. In a thin adult, the lower edge of the liver may be felt a finger breadth below the costal margin. It is most easily felt when the patient inspires deeply and the diaphragm contracts and pushes down the liver. Gallbladder. The fundus of the gallbladder lies opposite the tip of the right ninth costal cartilage. That is, where the lateral edge of the right rectus abdominis muscle crosses the costal margin. Spleen. The spleen is situated in the left upper quadrant and lies under cover of the ninth, 10th, and 11th ribs. Its long axis corresponds to that of the 10th rib, and in the adult, it does not normally project forward in front of the mid-axillary line. In infants, the lower pole of the spleen may be just felt. Pancreas. The pancreas lies across the transpyloric plane. The head lies below and to the right, the neck lies on the plane, and the body and tail lie above and to the left. Kidneys. The right kidney lies at a slightly lower level than the left kidney. It is because of the bulk of the right lobe of the liver, and the lower pole can be palpated in the right lumbar region at the end of deep inspiration in a person with poorly developed abdominal muscles. Each kidney moves about 1 inch in a vertical direction during full respiratory movement of the diaphragm. The normal left kidney, which is higher than the right kidney, is not palpable. Stomach. The cardio-esophageal junction lies about 3 fingerbreadths below and to the left of the ciphisternal junction. The esophagus pierces the diaphragm at the level of the 10th thoracic vertebra. The pylorus lies on the transpyloric plane just to the right of the midline. The lesser curvature lies on a curved line joining the cardio-esophageal junction and the pylorus. The greater curvature has an extremely variable position in the umbilical region or below. Duodenum. The duodenum lies on the transpyloric plane about 4 fingerbreadths to the right of the midline. Cecum. The cecum is situated in the right lower quadrant. It is often distended with gas and gives a resonant sound when percussed. It can be palpated through the anterior abdominal wall. Appendix. The appendix lies in the right lower quadrant. The base of the appendix is situated on 1/3 of the way up the line, joining the anterior superior iliac spine to the umbilicus, Mock-Burnous point. The position of the free end of the appendix is variable. Ascending colon. The ascending colon extends upward from the cecum on the lateral side of the right vertical line and disappears under the right costal margin. It can be palpated through the anterior abdominal wall. Transverse colon. The transverse colon extends across the abdomen, occupying the umbilical region. It arches downward with its concavity directed upward. Because it has a mesentery, its position is variable. Descending colon. The descending colon extends downward from the left costal margin on the lateral side of the left vertical line. In the left lower quadrant, it curves medially and downward to become continuous with the sigmoid colon. The descending colon has a smaller diameter than the ascending colon and can be palpated through the anterior abdominal wall. Urinary bladder and pregnant uterus. The full bladder and pregnant uterus can be palpated through the lower part of the anterior abdominal wall above the symphysis pubis. Aorta. The aorta lies in the midline of the abdomen and bifurcates below into the right and left common iliac arteries opposite the fourth lumbar vertebra, that is, on the intercrestal plane. The pulsations of the aorta can be easily palpated through the upper part of the anterior abdominal wall just to the left of the midline. External iliac artery. The pulsations of this artery can be felt as it passes under the inguinal ligament to become continuous with the femoral artery. It can be located at a point halfway between the anterior superior iliac spine and the symphysis pubis.